My next question, we kind of answering, but let's see if you have something else to add here. So why do you think that it's so important to have a broad clinical skill set and match the approach to the patient?
The ability to make a connection with a patient. First of all, it's personal, right? That's the one thing I love about physical therapy. We're not fixing toasters. You know, if you have a toaster, you can fix it any way you want. You don't have to ask the toaster. You just repair the parts. People are very different. We have to have them as an active participant in doing this most of the time. There are times when we do things and we're doing it and it works and they don't have to be as involved, but 90% or better, you have to have them really involved in what's going on, and the buy-in has to be strong if you really want the long-term positive, long-term benefits from these things. So to me, the variety is always important, because you may think, I may have guessed that, you know, I think I understand where this person's coming from, and I go to do something, and then as I'm doing a certain technique, some people, you know, it depends, it's just their perception of me as a person, or the clinic, or how they felt that day. You know, I'm too much on their personal space. They want less personal space. I need to have options. Oh, they don't, you know, oh, like they like to lean back. No, they really don't like that because they have sinus problem. Okay, I can do it a different way. Oh, there's tightness in their neck. You want to have these different varieties of ways of going at it, because some people, the technique, like I can tell you, Mulligan, if I use some simple examples, if we use a Mulligan technique on someone, but they're like, oh, I don't feel comfortable with that kind of movement while you're doing this. You know, okay, let's stop. We're going to go back. Let's go to a positional patient position. Maybe we're going to do graded mobilization instead. Okay, now let's go to mobilization with movement. Now let's go to active integrated motion as the patient moves along. Sometimes you may say, I want to, like, perfect example would be, I want to move this patient. Clearly, the best choice would be moving them through a McKenzie-style program of progression. But they're hung up. They don't want, their pain or their apprehension stops them. Well, if you put in some easy graded moves, which is part of it, but when you think of it in different terms, they don't want to go to the position I want. Let me go to a different one. Let me move them around and put in piece the tools from several schools of thought into the structure of progression you want through the one you want to do, and then you get yourself right back on track. I think of it as driving around an obstacle in a road. I don't have to totally give away the plan I want, but sometimes I have to go around an obstacle, and I'll do things that sort of get the patient to that point.